Welcome everyone to the June 8th, 2020 COVID-19 clinical care rounds focused on emergency medical services, COVID-19, and protests. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 EMS challenges and successes in patient care and operations. If I'm an EMS clinician preparing to meet the response challenges of COVID-19 and protests, the clinicians I want to learn from are those clinicians who have the most experience. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations who have collaborated. These are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges in patient care and operations with other clinicians. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we're using for these rounds. And thanks to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. Upcoming NETEC COVID-19 webinars are complementary to these clinical rounds and can be found on netec.org. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. On this Tuesday, tomorrow, June 9th, we'll have critical care rounds focused on the ugly tail end of the acute respiratory distress syndrome. This Thursday, June 11th, will be emergency department rounds focused on nursing recovery and preparing for a second wave. For the ECHO clinical rounds we've had to date, we've had participants from all states and multiple countries, predominantly physicians, nurses, and EMS clinicians. We continue to make this as interactive as possible by engaging expert discussants, crowdsourcing, and polling. We received many pages of questions and apologize that we're not able to answer all those, but hope we cover some of the major themes in those questions. With that, I'm going to turn this over to Dr. Bruce Struminger.
Great, thank you, Rick, and thanks to our guest presenters today and our expert discussants and to the nearly 500 participants who are joining us today. So I'm just going to go over a few logistical issues. To remind all our participants, there's a Q&A function at the bottom of the Zoom bar at the bottom of your toolbar. Please put your questions and comments regarding today's presentations there. We'll be reviewing the Q&A function and pulling questions out of that. Also, the chat function, if you've got technical or logistic issues, ask us about those there. And we will be sharing, Rick has a crowdsourcing question that he's going to be asking, and we'd love for you to put your responses in the chat to that open-ended question we'll get to in a few minutes. We are recording this session and your attendance is consent to be recorded. Thank you for that. The presentations and a link to the recording will be available on our website, and we'll share a link to that, and the email announcements also include links to the presentations. Today's presentations are linked to the announcement that went out earlier this morning and will be available in following announcements. We also will put a link in the chat at the end for CME and continuing professional development credits. Those are through the University of New Mexico, where Project ECHO is based. We'll put that link up about 15 minutes before the end of the session. It should also be in the email announcement that went out this morning. It's how we get feedback from you, so we really encourage everyone to take advantage of the continuing professional development credit. You'll get instant CPD, and we will get your feedback anonymously that'll help us improve these rounds. I'm going to hand the microphone now over to Sharon Van Arsdale to talk a bit about the NETEC upcoming webinars. Sharon?
Yes, thank you so much, Bruce. Hello, everybody, and happy Monday. My name is Sharon Van Arsdale. I am the Program Director for Emory Serious Communicable Diseases Unit. By background, I'm an emergency department nurse. I'm also the Director of Education for the National Emerging Special Pathogen Training and Education Center, and we are so pleased to be able to partner with Project ECHO on these clinical rounds, because this really gives us a great opportunity to kind of understand what areas do we need to do a deep dive on. And so NETEC's really been focused on doing those deeper dive webinars. We have an upcoming webinar on Friday, June 12th, that is on workforce innovations. So really looking at how staff have been reassigned and redeployed to different areas to help support the pandemic response. So thank you, Bruce.
Great, thank you, Sharon. I also just want to highlight that the AAMC is a partner in this consortium of medical societies and affiliated partners, and they've put together a wonderful clinical guidance repository, and the URL is here. We'll put that in the chat as well, so that they are constantly updating this repository, and it's worth your attention. And with that, Rick, I'm going to hand it back to you to discuss the Asper Tracy resource and also the Clinical Pearl crowdsourcing.
Yeah, thank you, Bruce. As this topic obviously evolved very quickly, one of the things I would direct your attention to is a resource on Asper Tracy. The link is there for you to take and run with. It's a resource for hospitals related to civil unrest, and realizing that we have a very broad audience usually for these rounds, EMS, hospitals, hospital personnel as well. Wanted to make sure you are aware that that not just exists, but was updated on June 6th. So it has a wealth of resources, peer-reviewed papers that might be helpful given the circumstances we're in right now. So with that, crowdsourcing. People really have increasingly been participating in the crowdsourcing pearls, and really would appreciate your responses to this question, because I think in the spirit of peer-to-peer learning, this helps us all. What is the most important thing your EMS organization has done to prepare for COVID-19 and protests? What is the most important thing your EMS organization has done to prepare for COVID-19 and protests? We could answer that one in the chat. It would be great for all of us to learn together. So with that, I'm going to ask each of the panelists to please unmute yourselves, and we'll go around the table, as it were. And if you would please let us know your name, title, and affiliation, that would be most appreciated. Paul, I'm going to start with you down in the right corner over here. Paul, please.
Paul Bittinger. I'm an emergency physician in Boston, and I am the director of the Center for Disaster Medicine at Mass General Hospital.
Thanks. Dave?
Senior paramedic David Gershner with Dayton Fire Department, and I'm the regional MMRS coordinator in West Central Ohio.
Thank you. Rob?
I'm Rob McClintock. I am the Deputy Director for Fire and EMS Operations at the International Association of Firefighters.
John?
I'm John Kramer. I'm the Director of the National Office of EMS, the National Highway Traffic Safety Administration, and the team lead for the Healthcare Resilience Task Force, EMS, and pre-hospital team.
Thank you.
I'm Dr. David Tan, President of the National Association of EMS Physicians and Chief of EMS at Washington University in St. Louis.
Thanks. Doug?
Hi, Doug Kupas. I'm an EMS physician with Geisinger Health System in Central Pennsylvania, as well as the State EMS Medical Director for Pennsylvania and an NMSP board member.
Thanks. Dan?
Hi, I'm Dan Gerard. I'm the EMS coordinator for the City of Alameda Fire Department, and I'm on the executive board for the International Association of EMS Chiefs.
Great, thank you, panelists, many of you who are leaders in your own right and with your organizations, but also, as I heard your introductions, I was also reminded you also have day jobs, most of you do. So it's kind of fun to listen. It was actually really fun to listen to. So with that, I'm gonna turn this over to our first speaker, Dr. Jeff Ho, Chief EMS Medical Director, Hennepin EMS, and Professor of Emergency Medicine at the University of Minnesota in Minneapolis, Minnesota. Jeff, please.
Hey, good morning, everybody. And from Minnesota, I'm going to try and share my screen here. Is that coming through for everybody? Okay, perfect. So thanks for the invitation to come back and speak. I was asked to keep this to 5 minutes and talk about COVID-19 operations during the civil unrest and rioting situation we've had in Minneapolis over the last week and a half or so. I'm going to talk less about COVID-19 and more about the civil unrest because I think that's what people are most interested in. So quick background on our service. We are a third service model based in Minneapolis. We run a two-tiered EMS system with about 85,000 runs for our service annually. We cover a fairly large amount of square mileage and about 240 employees and 6 EMS physicians and 1 fellow in training. Our EMS operations went live for COVID about March 16, probably when everybody else did. We have had the same ups and downs as most services with concerns for PPE and determining best ways to do aerosol procedures and things like that. And then on May 25, Floyd George died during a police restraint activity in the city of Minneapolis, and that sort of turned our world upside down. COVID-19 quickly became a very much a secondary issue for us. It was almost as if people forgot about it. And it was very difficult to sort of keep our employees motivated to remember that, hey, during the middle of all of this, we still have a pandemic that we are having to deal with. These are a few of the shots that I've put in. I have many, many more, but the area that you're seeing right here that's on fire is probably a mile and a half from our hospital. The other shots are stills of the National Guardsmen that eventually embedded with our EMS operations for protection. I basically just have 2 slides, and one is what worked and the other is what didn't work. And I can just spend a little bit of time on each one and then maybe take some questions on these. You know, it's hard to really plan for a riot. You can have all kinds of disaster pre-planning in place, but this is not really one that people expect. The one thing that did work really well for us is part of our equipment allotment for each of our employees includes impact helmets and body armor and things like that. We work in a very urban environment. We oftentimes are in the middle of situations that would be considered somewhat quasi-safe. I mean, they are made safe or as safe as they can be by the police, but because of that, we have to go in there and still operate. We do allow our personnel to purchase body armor as part of their uniform allowance. And with that, those are already on the personnel and in the ambulances when all of these things went live. And so if you haven't really considered any of that for your services, I would definitely think about that. Not every service needs to have that, obviously, but if you're in an area where these types of things can develop, that was something we did not have to go and try and find resources for. Our personnel already had that equipment on. The other thing that may have been obvious was that we really needed to have police escort into our areas of operation, and for a while we did. However, the police quickly ran out of resources, and after about the first 12 hours or so, we were pretty much informed that we were not going to be getting a lot of escort into these unsafe areas. We really had to come up with a safe plan on that. Very difficult to do when there's limited resources. We were able to get limited numbers of police officers riding with us for a very short period of time, also sending multiple vehicle convoys in to sort of do snatch and grab operations of patients into the hot zones. And eventually, after about 72 hours, the National Guard was activated and we were able to get 2 military personnel on each vehicle, and that actually worked out very well. Another thing that I would highly recommend in a situation like this, and we did very early on, is establishing unified command. Obviously, somebody has to be in charge of this incident, and the police clearly took control of the situation. But EMS can easily get forgotten in the background if you are not part of a unified command situation. And so we established full-time personnel in the command post as advisory personnel to the incident commander. Worked out very well for advocating for our needs and resources. Another thing that worked out well for us is the hot zones were continuously changing for us as the rioters would move from different parts of the city. And simply, again, the police just did not have control of certain areas of the city. And so if we were called to an area of the hot zone, we would stage outside of a hot zone, usually at a fire station, and await sort of a grouping of a convoy to get together. And then the command post would basically figure out safest path of travel in and out of the hot zones so that we had sort of a coordinated path of travel. That worked out very well. Also establishing no-fly zones. This was something I've not seen done before, but we had to sort of put a limit on the helicopter flights bringing patients into our tertiary hospitals, which unfortunately were very, very close to many of these riot activities. There were a lot of people in the crowd pointing lasers and actually gunfire up into the air. And so this was a safety issue for us in establishing no-fly zones around the urban areas of the city. And then last thing that I think is really timely that wasn't necessarily an EMS issue, but was more for the hospitals. You know, the hospitals definitely were not prepared for this riot activity to be happening right outside their doors. And we probably had at least 3 hospitals where riot activity was occurring just on the other side of their front door. Fires being set in their parking lots, vehicles being overturned, hospital windows being broken. And, you know, definitely things were not safe until about 72 hours into this when the National Guard was activated. But once they were setting up perimeters of the area receiving hospitals with safe travel corridors was absolutely something that worked well for us, and we definitely had to have. Some things that didn't work well, we found that we had to adjust our COVID-19 tactics a little bit. When we started COVID-19, one of the things we did, we operate a type 3 ambulance with a pass-through door from the front of the cockpit to the back of the box. And we closed those off and then would run the box at full ventilation during COVID-19. What we found during the riot activity is it was unsafe to leave that pass-through door shut because you essentially trapped our medic in the box. And they needed a safe path of travel out of the box in case the box was either invaded from rioters outside or the patient, who sometimes was a rioter in the back of the truck, became violent. So we actually had to start leaving that door open. Very difficult to choose which one is more important, but immediate personal safety wins the day on that one. Other things that didn't work is just being aware that even though we have a full-time PIO that works for our agency, getting on top of social media and regular media narratives was very difficult for us to do. And if any of you have seen the video of Mr. Floyd, the famous one where the police are on top of him, right at the very end, you see our paramedics come in, check a pulse, and then sort of scoop him and go back to the ambulance. And that was maybe 8 seconds of video that went viral. And EMS got criticized and still gets criticized very heavily for that, because I think what the context of what people saw was that EMS didn't stay right there and do what the public expected them to do, which was to start the resuscitation in the street. Now, from our perspective, they did exactly what they should have done. It was a security issue. They went to the safety of the ambulance and started the resuscitation there. But I think the media doesn't show that, and certainly our narrative on that was lost in trying to bring that forward. Other things that didn't work, local leadership, I think, did not recognize the deteriorating conditions of the public protest until it was too late. People at first were very peaceful, but that quickly degenerated into massively violent and very destructive actions. And I think people were very slow on the uptake of that. Other things that we had not considered prior to this was the initial period of EMS crew and headquarters security, where we had rioters outside basically the front doors of our headquarters. And we've not been in a situation before where EMS was seen as the bad or part of the problem or part of the bad guys, where they sort of lumped us in with anybody in a uniform working in public safety. So first time here in my 27 years that I've seen bricks and bottles thrown at the trucks in our crews. I think one of the other things that really doesn't come out in the narrative, and I'll be very judicious about my comments here, but you may recall that within the last 3 years, Minneapolis has undergone a fair amount of scrutiny for its use of ketamine as a chemical restraint in agitated populations. And one of the criticisms that came out of the last 3 years was that people felt that EMS was working too closely with law enforcement to sedate agitated people and get them properly and safely restrained. I happen to disagree with that, but again, that narrative didn't necessarily win the day, and our EMS service was ordered to sort of cease and desist training with local law enforcement on agitation, recognition, and control. EMS practices still remain the same. We still use ketamine in that, but I think what has deteriorated is that the police have not really been trained by us or with us in the last 2 to 3 years. And I think, unfortunately, some of that leads to a lack of recognition of what they are dealing with, which is how we find ourselves in this situation today with Mr. Floyd, unfortunately. So personally, I think that is a decision that we are paying for that happened a couple of years ago now. And then lastly, I'll leave you with, assuming that EMS or healthcare are the good guys. Again, first time I've seen where the public was sort of targeting EMS and healthcare as potentially part of the problem, which I think was an unfair portrayal of us. And with that, I'll leave my contact information throughout it all. We have been able to maintain our Minnesota nice attitude, as seen by our insignia on our buses that are going right into the front of the riots.
Jeff, deeply appreciate your sharing, and there's a lot of emails go out. Thanks for sharing. Seriously, thanks for sharing this. Well, I want to ask one question. In your role as EMS medical director, I mean, you and others across the nation have been dealing with COVID, living it every minute, and then suddenly we're in this space. From your lens as EMS medical director, what's the thing that you've done since the riots broke out that probably has had the most impact on your EMS system's ability to respond?
Without a doubt, that would have been prioritizing the safety and security of our personnel. I think it's one thing to say that we'll continue to respond and we'll continue to do all these things, but what quickly became apparent was our personnel were afraid for their own safety. They were afraid for what was being posted on social media. They were afraid to come to work and go into some of these areas, and frankly, I don't blame them. So we prioritized our personnel's safety to the point of informing the city that if they did not get us either law enforcement or military escort for protection, we were simply going to stop responding into these areas. And I think that was a wake-up point for the city. I think that was also a wake-up point for our personnel, where they saw that as, hey, our administration and our management truly cares about what was happening to us out here. They're not simply telling us to just suck it up and keep coming to work.
Thanks, Jeff. I'm going to turn this over now to our next speaker, Dr. Michael Sayer. Jeff presented once before, and then Mike Sayer was one of our first EMS session speakers. So it's great to have him back as well. Dr. Michael Sayer, Medical Director for Seattle Fire Department and Professor in the Department of Emergency Medicine, University of Washington.
Thanks,
Mike.
Rick, and thanks everybody to give me a few minutes here to kind of give a little bit of an overview of how our system has been dealing with the civil unrest and as well as the protests. Fortunately, Seattle did not have the same level of violence that other communities experienced. We did have a little bit of problems on a few nights, And there's still one small pocket of Seattle where there's ongoing protests that at nighttime devolve into some violent type activity. But most of the protests look more like this, are large and peaceful, with people expressing their views, creating maybe traffic disruptions, but otherwise are fairly straightforward from an EMS point of view with low impact. So what our group has been more worried about is the interaction between the people getting together to express their views, exercise their First Amendment rights, and to protest what they feel are unjust activities, and inadvertently transmitting COVID-19. And there's no question that this is a problem. Trevor Bedford has a large following on Twitter, and he's a virologist at the University of Washington. So he, over the weekend, had a large group of posts about this issue. And there's no question that when people gather together, even outdoors, there is increased risk of transmission. It's not clear whether that risk is as high outdoors as indoors. It's probably lower outdoors where there's wind. And there may be things that people can do, like wearing masks, but then there's also other activities that probably increase the risk, like tear gas, pepper spray, jail cells, and so on, as well as shouting. So the mix of positive and negative here is really unclear and is a concern for our organization. So we're continuing to monitor for COVID-19. And to date, we have not identified any uptick, but it's still very early. So daily counts remain stable. And right now, our incidence of COVID-19 is relatively low in our area. So hopefully there are not too many people in the demonstrations who are COVID positive. We do know that the disease disproportionately impacts Black Americans and other people of color. So these are our local data. And you can clearly see that Hispanic, Black, and Native Hawaiian Pacific Islander populations are disproportionately impacted by COVID-19. And many of people from those communities are also ones who are demonstrating and protesting. So we're pretty concerned that this could be a disproportionate impact on that community as well. Geography also plays a role, and in our area, the areas just to the south of Seattle are heavily impacted by COVID-19 as opposed to the core of the city and some of the other suburban type areas that are less impacted. And it shouldn't come as a surprise that communities of color are more densely populated in these areas and have a higher rate of positive disease. We're looking to see what we can do to help with mitigation as well by increasing our testing. So last Thursday, the city of Seattle started with EMS Help drive-through testing, and we're ramping that up pretty rapidly. So on Friday and Saturday together, we tested more than 500 people, where the people doing the swabs are EMS, with some assistance from other city workers who are learning how to register people and the like. We're going to bring a second testing site online later in the week. So we'll be able to test more than 500 people a day, and we're hoping to ramp that up even higher. We are messaging people who went to a demonstration that if they are concerned, they should get tested. And that messaging has worked because every appointment is taken for the next 3 or 4 days at these testing sites. So I think there is clear demand. We're also working to trace people. So we have a paramedic assigned to follow up with anybody who tests positive the next morning, and to urge their close contacts to come and get tested that same day so that we can track down others who may have the disease. So this testing is, as I mentioned, pretty highly subscribed. And there are no appointments left today. There's no appointments tomorrow. There's no appointments Wednesday. There's no appointments Thursday. You might be able to get an appointment Friday right now. So we're doing what we can to try to increase that capacity. The good news, as I mentioned, is that our overall positivity rate is fairly low. So we're doing, I think, a decent job in our community of keeping the disease under control, but that's only going to stay true if we actually follow through on the test, trace, and isolate policy. So impact on EMS largely has been minor. Last night we did have an incident that involved somebody getting shot. So that was concerning, and we remain pretty concerned about other things that could go poorly. But the good news is that PPE works. So this is data that we have published on a preprint and is submitted for peer review currently. And this shows that EMS who are wearing personal protective equipment, including masks, eyewear, gowns, and gloves, are protected from COVID-19 quite well. We had 700 providers who took care of more than 200 patients with COVID, and only 3 people out of that 700 who took care of patients with COVID have had symptomatic disease and tested positive. So the good news is PPE works, and I think that's key for protecting our EMS workforce from COVID. So with that, Rick, I will stop my screen sharing and turn it over for questions.
Thanks, Mike. I have one question about the PPE. The protests, they sprung up very quickly. And, from your perspective, when they happened, did you start thinking about changes in your approach to PPE, uniforms, protective equipment beyond, or like stay the course, or what? Yeah, where are you now with that and you're thinking about moving forward?
So as Dr. Ho mentioned, we have the body armor. We don't have enough for every firefighter. So there's a shared resource that gets deployed, and that's currently on the battalion chief rigs. So when there's a bigger incident, we are always sending a battalion chief to any significant scene of violence call anyway. So they carry armor in the back of their rig. And traditionally, and this has remained true during this event, the ambulances do not go into these scenes unprotected. So we have a long operational history of always sending at least 2 fire resources in addition to an ambulance, plus a battalion chief, plus a medic supervisor, plus police officers. So we put a big footprint on any scene of violence. And so that has worked well to protect our workforce. And fortunately, we've been able to continue that posture.
Thanks. And one more question, and then I want to go to the polling and then around the Hollywood Squares for comment and questions. So, Mike, this is specific about it's from Sarah asking, what is the optimal timing to get tested post-demonstration, and is that conveyed to the public?
Yeah, that's a great question. So I don't think we're doing a good job with that. When should you get tested? You should get tested when you start to get symptoms, and as quickly as possible. Ideally, the same day you start getting even a minor symptom. That would be the ideal time to get tested. Unfortunately, of course, you may have had some sort of pre-symptomatic viral shedding and have been contagious. So I think our messaging to the public on this to just go get tested has maybe not been nuanced enough. So out of the 500 plus patients that got tested on the first 2 days at our site, only 1 tested positive. So I feel like that's great reassurance for the other 499 or so, but didn't necessarily do much in terms of identifying people who maybe had the disease and didn't realize it. You're on mute, Rick.
Thanks very much. Thanks, Mike and Jeff, for great presentations. I want to go to the polling now. Again, I've mentioned it before. We all know these protests sort of sprang forth very, very quickly. And everyone's trying to figure out how to deal with this, and hopefully these polling questions will sort through some of that. So, okay, the first one, the number of days your EMS, oh, also, there's on these questions, you will see not applicable, realizing that some who are participating in this peer-to-peer learning session are not EMS providers. There's a not applicable one there for you, and some of the questions might not apply anyway. So at any rate, the number of days your EMS organization has responded to protests. This is just trying to gauge, your engagement with, your involvement with the protests so far. It's a pretty straightforward one. Okay. 29% said 0 and 15% said more than 5. Wow. I've never seen a curve quite like that. I don't even know what to call that curve. Opposite of Bell. All right, next. During protests, most of our EMS responses are to the following: injuries, medical, about 50-50 split between injuries and medical, tear gas, pepper spray, don't know, or not applicable. And yes, I realize tear gas and pepper spray, you can do the injury thing, you can do the medical and so forth, but I think you get the point. Just select one. Most of our EMS responses are to the following. Okay. Huh. All right, thank you. Speaks for itself. Next. To prepare for COVID-19 end protests, our EMS units have added, select all that apply for this one, okay? PPE, bleeding control kits, eye flush solution, other, not applicable. So all that apply, all right? Okay. Wow, interesting. I kept thinking, so when I made these up, I kept going, okay, so what's the other ones? What are the other ones? I should have done a chat on it. All right, next. During the current protests, our organization's EMS clinicians, EMTs, paramedics, wear PPE, body armor, and helmets. Third selection is PPE and body armor and helmets. Other and not applicable. Okay. All right. PPE, by far the clear winner. Thank you. Next one. My single biggest concern about COVID-19 and protests is, so you get one choice here, EMS clinicians being injured, EMS clinicians being exposed to COVID-19, vehicle-borne attack, mass shooting, or transmission of COVID-19 in community. You just get one. And everybody can vote on this one. It's not to EMS organizations. So there's 500, I don't know, 500 and some, 593 people. See how far we can go with this one. Okay. Hey, Jeff Ho, that EMS clinician being injured thing. Yeah, how about that?
I think that's probably right on. That needs to be first and foremost. I also consider a COVID-19 exposure as a form of occupational injury, although it may be later exposure.
Yeah, I understand.
not
Yeah.
acute.
Yeah. Yep. Yeah. Thanks. Next. At the time of presentation to EMS, what percent of patients in protests are wearing a mask? So at the time that a patient presents to EMS, what percent of patients are wearing a mask? None, less than 50%, approximately 50%, greater than 50%, don't know, or not applicable. Okay. I think the highest one, other than not applicable, was less than 50%. 23% said that, indicated that answer. All right, next one. Percent of patients cared for by my EMS organizations during protests who are transported to hospitals. So what percent are transported to hospitals? The simple way of saying that one. You see the ranges there. Okay. It looks like 1 to 25% is the most frequent, other than not applicable, 17%. All right, thank you. Next. I think that this one might be the, no, next to the last one. Okay, my EMS organization's COVID-19 and protest plans, as in the combination, are being written and implemented, being revised, don't know, or not applicable. So it's your plans. Okay. Written and implemented, 20%. All right, next. This last one, as you who have been participants on these rounds, any of our rounds before, we spend a lot of energy on PPE because you spend a lot of energy telling us we got to work on the PPE. All of us need to work on the PPE access issues. So this is a sort of like a trending. We just want to see if in your EMS system in the past 7 days, is your access to PPE while carried for patients better, worse, or the same? All right. Same, by far the winner, 72%. Better, 24%, worse, 4%. Well, the good news is only 4% said worse, or the bad news for the 4%, hard to say. So with that, let's go to, I'd really like to have each of our panelists, so we've got like 15 minutes or so, spend 1 or 2 minutes commenting on what you've heard from our presenters, and any questions you might have, and the polling results as well. John, I'm going to go to you, and then I'll start with Paul and go around. John, please.
Thank you to both of you. Specific question really for Jeff. You had mentioned something that you hadn't seen earlier, and that was the establishment of no-fly zones because of the location of the hospitals to a lot of the unrest. Do you have any sense of what impact that may have had, and how did the community, what did you do to compensate and try and mitigate the issue?
Yeah, so great question. The sense that I have of impact is that the no-fly zones encompassed a children's hospital, which is a level 1 trauma center for children's, another level 1 trauma center and tertiary receiving hospital, which generally receives the most complicated patients from all over the state, and a third hospital, which is a leading stroke and myocardial infarct receiving center. So it really took down a significant portion of our infrastructure as far as the state of Minnesota and the spoke, sort of the hub and spoke receiving that we get from outstate. Compensating wise, we do have other trauma centers surrounding around the state. However, they are longer transport times. We don't have any other verified pediatric level 1 trauma centers. So I'm not aware of any cases there that were pediatric in nature that had a bad outcome because of that. And I think we tried to limit the no-fly zone hours to primarily after dark when people could not see where the rioters and the protesters were. So really it was for approximately 12 hours per day on at least 3 or maybe 4 days. So those were the mitigating factors. I do think we got through it okay. It's not something I really want to see happen again, but I think it was the right move. I would hate to see an aircraft brought down because of something like this.
Thanks, John.
Thanks, John. Paul.
Now, so certainly want to thank the presenters for their presentations. I don't know that I have too much to add other than, at least in our experience here, the tenor of what we're seeing is really changing. That early on, there certainly was a lot more anxiety. There was a lot more conflict with law enforcement, and there was use of some riot control agents. But although we still definitely have ongoing protest activity, it's much calmer, and really, I think everyone is peacefully coexisting pretty well, which certainly I hope is the case increasingly in other cities as well. I think our emphasis right now is very much on supporting the same COVID mitigation activities, making sure people understand the importance of wearing masks, making sure that when possible they're taking the same protective activities as otherwise. But I think again, important to notice that at least in significant parts of the country, the tenor of these the protests are really changing.
Thanks, Paul. Alex.
Oh, thanks, Rick. Somebody asked the question and then Mike started to answer it with regards to testing, maybe after, having to engage a group like this, or even among protesters, like when should they get tested? I mean, his answer is right on target. Well, clearly, if you're developing signs and symptoms of COVID, you should get tested. Then the other question might be, well, is there some proper timing if you remain asymptomatic, understanding that you can have asymptomatic, pre-symptomatic infection, asymptomatic shedding? And I wonder, since the mean time for incubation, even though it's 2 to 14 days, but the mean time is about 4 to 5 days, I wonder if that isn't a reasonable time, 4 to 5 days, 6 days after the exposure, you get tested. And then if you really wanted to be complete, you could get tested one more time, before that 14-day period were over, if you were really concerned that having engaged this group put you at greater risk for exposure to COVID-19. Any thoughts from the panel on that?
I think that makes sense, Alex, as long as there's testing capacity. So I think what I was expressing is concern that we've overwhelmed our testing capacity with this messaging. And therefore now we have a long queue. So the people that are symptomatic aren't going to be able to get in. They'll have to go back to what they had before. So there's a nuance to this for sure.
Thanks, Mike.
Thanks, Alex. Dave, I'm going to go to you as I do that. I do see, just to let you know, I am paying attention in the chat piece, and I see question about trying to, or suggestion to do a polling question around differentiating when I asked about the PPE access, better, same, or worse, to add a same and adequate and same and inadequate. So for future trending, I get the issue. Mike, speaking of nuance, but it's a really critical one, and I get it. So we'll work to do that the next time. I took a picture of it, so like did the iPhone thing. So we got it. We'll do it the next time. Let's see, Dave, to you.
Thank you very much. I also add my thanks to the presenters. This has been very helpful information. I have one comment and then one question. My comment is simply to say I'm really saddened and disheartened to hear that EMS was targeted and that projectiles are being thrown at the ambulances. I think before, certainly, EMS, as you said, was viewed more as a helpful resource to anyone who needs help. And to see our EMTs and paramedics targeted is very concerning. My question is to both. I'm pretty sure that an N95 won't filter out chemical agent like CS and CN. So, but the other converse, I'm not so certain of. In other words, if our providers have to take an N95 off and put a gas mask on to respond to a patient in an area where there may be chemical agent in the air, or just because of the environment it has had to be deployed, do you think our providers are at increased risk of contracting COVID-19 then? Because I just don't know the answer to that question, if CSCN filters would filter out viral particles, in particular SARS-CoV-2.
I'll take a stab at answering that. I think we're going to find out here in about 7 to 10 days. I mean, I don't know the answer to that either, Dave, but I think we're going to have some pretty good data in about 7 to 10 days that will tell us.
Yeah, it'd be very interesting to see what your experience is there, because I just don't know. Thank you again.
I think the answer is in the chat box from someone who maybe actually knows the answer.
Mike, I'm not seeing it. Do you see? Or can you share what you're seeing there?
Sure. I am a CIH. Gas mask will protect v COVID, but needs to be doffed properly. I'm sure that feels true to me. Let's put it that way.
Yeah, thanks. Okay, so Dave Gerstner, how about you?
Well, Rick, two more fantastic presentations, and I'd like to thank both of the presenters, and I want to thank you and John for putting these on. I think I've only missed one of these since you started, and certainly Project Echo has been amazing support for this. There have been a lot of comments in chat about the different reasons people may be wearing masks, whether it's to provide anonymity or whether it's to protect against COVID. But I will say that in our first one last Saturday, and I, by the way, want to agree with Dr. Bidinger's comments that ours have become less violent over time and less confrontational. But in our first one, we had a large percentage of the crowds that were not wearing any masks. Our media put out a lot of messaging about the risks of COVID transmission, and we have seen an increase in COVID in our primary county, Montgomery County here in Dayton. And as time went on, the number of people wearing masks increased. No way to know what their motivations were, but nonetheless, we were seeing more people in masks, and I thought that was a good thing.
Thanks, Dave. Appreciate the kind comments as well. Rob?
Yes, I just wanted to thank both of the doctors. Their presentation had some awesome information in it. It's really great to have these presentations. Just to our providers out there, keep your situational awareness in high gear. Keep yourself and your partner safe. Remember, you're still number one out there. The other thing is take time to take care of yourself, both mentally and physically. I did have one question for Dr. Ho, just to see if he had anything in place right now for like peer support for your members, because it's like I said, it's so hardened to hear that EMS is being attacked like this, and it's definitely not something we're used to. So I'm just wondering what you have in place for your providers right now.
Yeah, great question. Let me respond to the piece about the providers being attacked. I am not so certain they're being attacked as providers. I think what has happened is we had amongst the protesting a group of people that were somewhat anarchists that came in with the sole intent to disrupt and destroy sort of infrastructure. And so anything acting in official capacity was fair game for them. So I don't necessarily think we were targeted because of the fact that we're trying to help people. I think we're targeted because we're just part of the governmental machine, if you will. To answer the second part of your question, we definitely have and continue to have wellness types of things going on for our personnel, including my EMS system is a third service, part of a healthcare-based system. We have taken full advantage of our clinical psychologists. During the heaviest portion of the activity, we had 2 of them in our headquarters 24 hours a day for personnel to come in and just sit down with, talk to, exchange ideas with, etc. So we have not had them 24 hours a day anymore as things have sort of died off, but they are constantly available to us. So that's a good example of one of the things that we've done and found very useful. But good question, thank you.
Thanks, David. Doug?
First of all, this has been a terrific session, and I'd like to make an observation that is a little bit broader than what has been covered here. I think that the rioting started with the unfortunate restraint and death of an individual, with lots of other layers of issues with it. And EMS does restraint of patients too. And since NAMSP published the position statement on use of restraint by EMS about 20 years ago, I think there's been a very significant decrease in the practices that have led to untoward effects in EMS restraint. But I would just say that I think this is also, this is an opportunity for every EMS agency to, right now a lot of focus is on police cases, but I don't want to see the next one be an EMS case where it's an EMS crew that does a restraint and somebody has an issue. So I think people should be looking back at NAMSP's position statement, other best practices, making sure your agencies are prepared with the way that they appropriately restrain patients. And, I think the other layer on top of this is, there are varying degrees of racism and other biases across EMS providers, as well as, our general society. And we should be making sure that our agencies are doing everything we can to work toward better diversity practices and extinguishing those kinds of characteristics.
Doug, really important perspective, making sure we focus on EMS providers and how we're providing our own care, for sure. Sharon, I know you may not be out in the streets providing EMS care, but you may have you probably do have some important perspectives on this.
I think really appreciate the presentations today, because I think it was eye-opening. I am not on the street, but that I have more gratitude and appreciation for our frontline providers than I did before coming on. Because not only are our frontline providers having to battle and deal with a pandemic, you're now concerned about your own safety. And so I just really huge appreciation out to our first responders.
Thanks, Sharon. Dan?
Hi, thank you to both doctors for your excellent presentation. Mike, I have two questions for Dr. Ho. First, since the incidents have unfolded in your community, what have you done to facilitate communication with the public and local community leaders, and specifically groups that are associated with the protests? And then my second question is, what has been the street medic interface with the street medics that may be embedded with some of the protesters? We see many of these programs coming online, facilitating the embedding of paramedics, nurses, and physicians into these street medics into the protests.
Okay, so I'll take the second question first. That's the easier one. We have had very little interaction with the street medic type of personnel. It's our experience that when we get called out to take care of somebody in the field as a professional EMS agency side of things, that person has already sort of been removed from the group protest environment, if you will. And so there isn't necessarily a field medic that is standing there trying to offer care or do something else. So we have not really had to do much as far as interact with those folks. It's also my experience just in dealing with the police intelligence of the street medic concept out here, that many of those people are very, very rudimentary trained medical personnel, like very basic first aiders type of thing. So I'm not sure that all of them have any sort of level of medical expertise, but we really haven't had much to do with them. To take your first question, which is what have we done? You know, honestly, we have largely stayed out of the media spotlight, if you will, and tried to just do our jobs. That's been a calculated decision to not really open ourselves up to try to draw friendly fire. I mean, we are in an environment right now where the media is clearly looking for a story that sells, and what is going to sell is if you somehow do something that becomes controversial or gets people's attention. Our job is to right now come to work and do our jobs and call as little attention to ourselves as possible. I think a day will come when we will be able to adjust that message, but that's not quite yet.
Thank you, Dr. Ho, and I'll hold a good thought for the men and women of your service. Thank you.
Thank you so much.
Thanks. Dr. Kramer, before I turn this over to our speakers for last words, comments from you.
This was pointed out, you know, over the last 4 months, we've had 2 significant healthcare challenges that we haven't had to face in the past. One is an infectious disease of the magnitude that we have, and then physical events that have compounded it. A lot of good information has been shared, but we've got to bring the community together and look at lessons from both of those individually and combined. That's one of the things that I think we have to focus on.
Thanks, John. Let me turn this over to Michael and then to Jeff for final words, comments.
Sure. So I want to thank everybody for their great questions and for their interest in this topic. I think we do need to remain concerned about the possibility that this protests and are going to lead to increase in COVID-19, but I don't think it's going to be an overwhelming number of cases. It may increase the proportion of deaths, however. And so I think whatever your EMS can do to help mitigate some of that harm, I'd urge you to continue to get engaged in that.
And I don't think I have much else to add. I've been trying to respond to some of the Q&A online as well. But I think people have my contact information. I appreciate the opportunity to present today. So thank you very much. And thank you for the support of my agency and to all the men and women of EMS.
Thanks very much. Bruce, before I close out.
Thank you to Jeff and Mike and to our expert panelists. It was really very informative. Thanks for sharing your experiences, and be well.
Yeah. So, you know, at the beginning of these rounds, and yes, I say it over and over again because it's important that people know that these echo clinical rounds are focused on clinicians sharing their successes and challenges with other clinicians. And I think this might be the one that exemplified this, maybe the best of all the 30 some that we've done. It really was sharing of your successes and challenges. And Mike and Jeff, just so you know, reaching out to you when you're like getting creamed is like, yeah, you beyond stepped up, and I'm deeply appreciative of that. For the participants who have participated, the one message for participants is, as I have said in some of the introductory comments, the nature of these are changing and will continue to change as this pandemic evolves, and you know, how the pandemic is influenced by other really hard events. We just did protests. I got an inquiry about hurricanes. The fires are coming, the floods are coming. And while you may not be in an area that has hurricanes, you may learn quite a bit about the hurricanes, or you may not have had a protest, but I'm guessing you really learned a lot today about EMS and a response far beyond what you're seeing right in front of your faces. So with that, yeah, pay attention to what's coming up, and hopefully we can continue the opportunity to share and learn from each other. To our panelists, great discussion. Seriously mean great discussion. And Mike and Jeff, deeply appreciate it. And thanks, Echo, to the platform. With that, thanks very much all, and we'll see you on the next one. Bye.